Finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
All right, everybody, welcome back this week. You got it. You requested it. It's our third week in a row or fourth week. I think it's the third week in a row of more COVID questions and COVID stuff because you want it. So this week we have a very special guest who will let you in on the secret in a moment. Talking about a new perspective, which is a nurse's perspective on COVID and another country at that. But before we dive in, Tim has got a very special message from our sponsor, a tongue-twisting tripler, aka Dr. Seuss thing that I'm not reading today because I will butcher it. So he's going to go for it, and away you go.
It's story time brought to you by locumstory.com. Today we'll be reading Docs in Shocks. Some docs are overworked as work works overworked workers weary. Some docs are stopped as pandemic TikToks keep docs off clocks. If docs are in shock as the pandemic clock TikToks, then locums is the token to unburn the burned out broken. So how many clock TikToks must talk until docs tick box and swaps to the spoken locum tenens token to unburn the burned out broken? Enough ticks have talked. The time is now, and locums is how. Locum tenens tends to trend as a godsend mend to burned out ends. So for more amazing poetry and help with locum tenens, you can go to drpodcastnetwork.com /locum story is your final destination.
So I will put the link in the notes in case you're interested in something that fun. All right. Today, long awaited. I've been wanting to do this interview for a while. And finally, we have my sister, Heather Burgess. Hey, good to have you, sis. So Heather is an ICU nurse, and she works in Canada, has been on the front lines of COVID right through the thick and thin, right from the beginning as well. And so she is going to give us her take on how things have been going from a nurse's perspective, all about COVID, how they're managing it, have been managing it in Canada, the Canadian perspective, as well as the ICU nurse perspective, and what that's been like. So welcome, Heather. Yay. So, hey, super fun to have you on. All right. So, why don't you tell everybody how long have you been a nurse for?
Well, 14 years now. I've been an ICU nurse for 10. So it's been a while.
I
Yeah,
thought it was 13.
14 years.
That's how much I know.
Yeah, I'm going into my, well, 13, going into my 14. Feels
All
like
right.
my 24th.
No kidding, right? Yeah.
Yeah.
And the population base, where you don't have to tell everybody where you work in Canada, but the
Right.
population base is catch
So-
area. How big?
Right. So, well, we're in a province of just over 1 million people. And in the greater metropolitan area where we live, I would say we serve about, 320,000 now.
Okay.
That's our,
How many ICU beds are in your hospital?
So the hospital that I am in, we have 15 beds, but we also have an overflow unit. So that's an additional, has 7 beds in my hospital. And then the other hospital has 15 beds as well. And I believe they have the capacity to increase about 10. Don't quote me on this, but I believe it's an additional 10 beds.
So you have about a 500,000 person catchment area for give or take about 47 ICU beds if you use the overflow.
Right. Yeah, that's right. And then in addition to that, you just keep in mind as well that, because we're the primary care center for the province, we also serve a large portion of the north. Anyone that's requiring, immediate services such as a cath lab or neurology or even immediate dialysis, they need to come to Saskatoon. They need to be flown in. So we also get a lot of people that are sent in by plane or by air ambulance and STARS as well.
So before COVID hit, how many, like on average, how many like beds would usually be occupied in the ICU?
Right. So prior to COVID hitting, we were staffed initially for 12 patients, so 12 beds. Ideally, our staffing ratio is 1-to-1 nursing. And then, of course, when COVID hit and that took off, numbers went up. So we could safely function probably with 15 patients and 12 nurses. Sometimes we can double up patients. But now that COVID has hit, these people are considerably more sick, requiring a lot more care. So one nurse can be running up to 10 drips on a patient at the minimum. In addition to which, a lot of these COVID patients require proning, where we actually take the patient and flip them on their stomach, which requires a lot of manpower, of course. So, it's definitely 1-to-1 nursing care and then some. But now that with the explosion of COVID and us not having enough critically trained staff, we're forced to take care of right now in some instances of 2 patients. And so it's been a really big strain on our resources for sure.
So when did it start to get really like noticeably busy?
Mhm.
Can you remember how far back that was?
I do. So I remember back when COVID started, and it was not touching our ICU. I mean, it was still all the way over in China and working its way kind of around the world. And we were all, of course, just like everybody in the States or everywhere, freaked out, not sure what to expect, just not sure what was going to happen. We really started to notice things, I would say, would have been in February, March. Um, and that's kind of when kind of things kind of tanked for us. Our ICU got full. And
That was 2020.
right, right. Yes, sorry. So we're
Yeah,
yeah,
yeah.
2021. Um, so that's when, things really started to get crazy. And we had a good 3 to 4 month run of we had more patients, but it was, and there's the odd time that we worked short, but um generally speaking, it was somewhat manageable. And we did seem to get the numbers under control for a while, or so the government thought, right? Of course, restrictions were lifted. And since that has happened, well, surprise or no surprise to us, we've now entered a fourth wave, and it's the worst wave yet. It's it's far worse than the other waves that we've seen. And with that being said, with the exception of one individual, all of them are not vaccinated. The one
How
that
do you
was
know they're not
vaccinated,
vaccinated?
yeah, the one that was vaccinated is immunocompromised.
Yeah, but how do you know their vaccination status?
Do they ask that when they're
Do they
admitted?
do they tell you that? Does the family
Yeah,
tell you?
yeah, we get that information. Yeah.
So when they're admitted, somebody puts on there that they're not vaccinated?
Hmm.
What's in the chart?
Yes, that's correct. And we can look up on our charting system. It's called eHealth, so we can have access to that information.
So do you have direct access to their vaccination records in the province?
No, I do not have direct access to their vaccination records in the province, but we do get it. We do get that information from the family or the patient when they come in.
So like so if they come in and they say they are vaccinated and they can kind of tell you which one and when, you can look it up to see what it
And
is and check and backtrack.
yeah, we
And
can
right,
backtrack that way.
Yeah,
And
because there's a lot of so did you see a big decrease? I mean, obviously cases don't mean I don't think cases mean shit, really. I mean, other than maybe for tracking purposes to a degree. What matters is what you do. I mean, if you get mildly ill and you miss a couple days of work, great. You have natural immunity. You're good to go. What matters is what you do. What matters is, especially, hospitalizations, but especially ICU admissions. So, when vaccination started, which kind of was slow in Canada, but ramped up probably March, April of this year, did you see an initial dip in admissions, or did it always just kind of slowly get worse and worse and worse?
I think that I think thinking back on that, I think it plateaued. I wouldn't necessarily dipped, but I would say it definitely plateaued. Um, there didn't really seem to be a drop off where the number of our ICU admissions dropped. It just kind of plateaued. And then once they were, more into the vaccination phase, pushing the vaccines out there, we just kind of leveled off and plateaued. And then, of course, when summer came, they lifted our restrictions. And then, of course, no one's masking, everybody's out and about. And then, shockingly, 6 weeks after that, you see that, immediate spike in cases coming into
Right.
the
But if you got,
Wow. So you noted that though, really about 6 weeks after the restrictions were
Oh,
lifted,
definitely.
the spike in
Yes.
cases, and then in ICU admissions as well.
Hmm. Hmm.
yeah, they
Yeah.
follow. They're
Yeah.
like a 2 week
I
after.
know. I know. Just after she saw that.
No,
So,
but the thing is, if the vaccine worked, I mean, you have about 65% of fully vaccinated patients in, in,
I think we're at 73 now. 73.
yeah. And that's, 2 weeks post second dose or 2 weeks post J&J. So that's significant.
Hmm.
And so, I mean, my contention has always been, I mean, I think you have to be Helen Keller to not see that this has made a significant difference, at least in hospitals. I mean,
Hmm.
obviously the people right now in North America that are really sick are largely unvaccinated. Okay.
Right.
That isn't really what's going on in other parts of the world right now. But if the vaccine actually worked and you're at 73%, it should have stopped spread. And it clearly didn't do that. And I mean, that's the part.
so you're saying you, vaccinated person, should not be spreading it to unvaccinated people if it
You
works.
shouldn't be spreading it to anybody.
Right. No, that's what I mean.
Yeah.
That's what I'm saying. Yes.
Yeah.
However,
I mean,
I would like to add though, just, when we start talking about like the, vaccinated versus unvaccinated, you also have to take a look at those numbers that are in our ICU and what areas they're from, right? Because a large portion of our patients that are admitted are from northern communities where there's a lot of mistrust in the healthcare system and the government, and so there's not a lot of uptake with in the Aboriginal population, for example. Um, we've even had I've had patients tell me that their priest has even said not to get vaccinated because God will take care of them. So there's a lot of mistrust among the government and healthcare systems in Aboriginal communities. So we see a large number of our patients are from, those northern communities where, vaccinations are still kind of regarded as, I don't know, as evil, but there's just a lot of mistrust there. Or in the Hutterite communities, for example, we had a huge spread event happen where we had a few actual people from the same communities again admitted with COVID because they were at a large function. And of course, a large portion of those people did contract COVID, and a few of them did require ICU hospitalization. So we were seeing initially, like with these admissions, it was all kind of contained to northern communities, specific areas within the province where you had different, you know, different religious backgrounds, different belief systems. However, now that's not the case. Now we're getting all
So
admissions.
we'll get to that.
Yeah,
Okay.
Riz.
But if you were from a native reservation in Canada,
Mhm.
why the hell would you trust the government?
Well, that's a whole other show.
I mean,
That's a whole other show.
Yeah, no kidding.
no, but it's true.
Right.
I
Well,
mean, they just unearthed this spring, like all these, from these residential schools where they were burying kids on
Right.
top of each other.
well, yeah. I mean,
So-
there's
so,
a
I
whole
mean-
pile of baggage there. But so I mean, really, for
Yeah, but if what I'm
purpose,
saying is it makes sense.
yeah,
Like it makes
right,
sense for them to not trust
right.
the government,
Oh,
right?
trust.
It's
Oh, totally. Yeah.
So initially, though, it was pretty much. I mean, obviously there was everybody getting it, but it was pretty much pinpointed to clumps and groups of social communities. Is that that you were seeing initially? Yeah.
Initially.
Okay. Right. So now tell us about, I mean, it's hard to it's just generalizations from what you're seeing, but what's the demographic? Is it all across the board? Is it still predominantly more like the indigenous people? Is it or like initially, or is it now just a whole wide spectrum across the board,
I think now
denominations and races?
that's kind of where we're at now. I think now it's just a wide spectrum. We're seeing a lot. The age gap is widened completely. Originally, like I was saying, we're looking at primarily, people in their 70s, 60s and they all have the same comorbidities of being a diabetic, being obese, having hypertension. Now we're seeing people of all ages. We had a patient here the other day, I believe that was 25 years old. Um, and no other comorbidities. We had to actually put her on ECMO, which is for you listeners, the heart bypass machine, because she contracted COVID. I think when she was at the exhibition or something like that. But all ages, all socioeconomic.
So like like otherwise healthy individuals and completely sick with
but how common is that? Because the outliers are the ones that you remember, right? I mean,
Mhm.
it's like you'll kill 55,000 people in car wrecks in the United States a year, but if two guys die in a car, in a skydiving accident, then it's national news.
well, if it's becoming more common,
It is more
Right.
common
No.
now.
who
I would
knows?
say definitely. And, you know, more people in their 40s and 50s are coming in, like my age that I'm seeing. And like I said, no pre-existing conditions. Other than they were, steadfastly against the vaccine. And
What's
that's
the
been my experience.
so what's the youngest person that you've had in the ICU there? Or what's the youngest you guys take? Do you do pediatric? You don't do
We
peds,
don't
do you?
do pediatrics. They go to the university hospital. So we would take anyone 18 years of age and older.
So what's the youngest you've had, the 23-year-old?
Yeah, I was 23, 24 years old that I've
Okay.
seen when I've been working.
Okay, so that's admitted, that's not necessarily dying from it, correct?
I'm talking about admitted to the intensive care
Right.
unit.
Right.
There is a floor in our hospital dedicated to COVID admissions. So they would come in through the emergency department, be triaged, and then decided where they would go. So that might be they'll be admitted to the COVID ward where they'll be monitored. And if their condition deteriorates, then they would come to the ICU for further interventions and treatment.
In your experience, because you've done this a lot, if you're intubated, what's your chance of survival?
It's 50-50 at this
So you
point.
actually have had some.
We have
Well,
one of our lead physicians, Dr. Sabira Valiani. She's great. She's been doing a lot of research, and the other docs have as well. But at this point, we're seeing it's 50-50 shot. There's been, COVID is something unlike anything I've ever seen or experienced in my nursing career. I was a nurse through the H1N1. When that came out, that was a big deal. But this COVID pneumonia is very unlike anything that we deal with on a day-to-day basis. We do deal with people in acute respiratory distress, and them are called ARDS that some people have heard. With this COVID type pneumonia, it's very, very difficult to ventilate these patients. It's like trying to ventilate someone with cement in their lungs. And so the way that we run our ventilators, it varies patient by patient. Um, every person is completely different ball of wax. And so their needs change and vary. It's not easy textbook. This is how you treat a COVID patient because everyone is so different. But I can say that the number one treatment that we do right off the bat when they come in is proning. So whether they are on life support, intubated or not, we get them to lay on their stomach because by laying on your stomach, of course, you improve their ventilation and oxygen exchange because gravity takes over and those lungs can kind of fall down and and hopefully improve their oxygen exchange, which it usually does in a lot of people. But you try getting somebody that's 100% oxygen on a BiPAP mask to lay there on their stomach for, you know, 12, 16 hours, and it's not easy for them. Um, and so at that point, we kind of take over, and then we intubate them if we have to. But the doctors are finding, the longer we can go proning someone, the greater their chances are. But as soon as we intubate, no matter what the age is, their chances dramatically change to 50-50.
I was actually surprised it's 50-50.
Hmm.
But for sure early in the pandemic, it was way worse than that because,
Hmm.
they thought that this was ARDS. And so they would intubate them in the ER like you would because
Right.
intubation, rest. But this is totally different. I mean, one of the theories on the pathophysiology is it's primarily a clotting disorder. And so they're getting micro clots in their lungs. So their lungs become completely stiff and they have no ability to have gas exchange. Whereas ARDS is almost the exact opposite. Your lungs become leaky, they leak fluid. So if you can overcome the fluid with pressure, you're good to go. So you want early intubation, super aggressive, respiratory therapy, and then you have, plus steroids and all the usual stuff you get for pneumonia. So it's a completely different world. Even though, what killed virtually everybody in 1918 was ARDS. They had no name for it. And it took them 2 or 3 years after the pandemic to actually agree that it was a flu virus. So
So I'm curious for you to kind of walk us through what happens when someone comes in, because obviously, if they're on the floor to begin with, they can be out on the floor and be proned, correct? I mean, why they
Right.
can be
Correct.
proning people out on the ward. So I guess once someone's sick enough that they need to get into the ICU and have that level of care, um, like you said, that's usually the first thing that happens is you're flipping them on their stomach
Right.
to help them with drainage from their lungs, with gravity taking over. You're trying to keep them off of ventilators by using BiPAP, which is a pressure flow system, kind of like people know what CPAP is. So it's akin to that, keeping your lungs open.
CPAP with a bonus.
There you go. Is pretty much everybody on BiPAP at this point when they come in, or are people staying on high flow oxygen?
A bit of both. So typically, yeah, they'll be on, one of two things. One is called BiPAP. So that's for people that don't know what BiPAP is, it's like having a CPAP machine at night. It also keeps the airways open so that the pressure comes out both ways, basically. And then the other type of oxygen delivery system we use is called OptiFlow. So that's, extremely high flow of oxygen through your nose. And that we can run up to 100%. But when they come to us, we try to hold off as long as possible. But when we do admit them into the ICU, basically they're at the point where they are needing intubation. We try to hold off, especially on the younger people, as long as we can. Um, and not intubate them. But by that point, they just become so fatigued that we need to take over. And so
So
that's what we do.
So obviously, respiratory lung function being the main thing failing, right, to bring him into ICU. But what about other organ systems? Are you having anybody show up into ICU, COVID related organ failure, not respiratory first, like renal failure from any systems or anything they've been on in the hospital
No,
or cardiac? No, pretty much
nothing,
all.
no, nothing that I can think of offhand. No.
Are you using
Okay.
remdesivir?
So yeah, tell us about all the things that
Are,
go that go
are
go
you
on
are
and
you
what
using
you're using for protocols.
are you using remdesivir in Canada?
No. What's the other name for remdesivir? Is it just a we primarily are using steroids.
And
Yeah.
anticoagulants, I would assume.
And oh yes, anticoagulants, definitely.
Some really good evidence that very early anticoagulation makes a massive difference.
It does, and that's the very first thing actually we do. Um, of course, is anticoagulate. I've seen many complications with PEs, um, microclots. We've had a lot of our patients, of course, once they're intubated, they don't wake up, and that's kind of been interesting for us because I mean, we've had several patients actually. I mean, we consider these people are intubated for a lot longer than a standard pneumonia or whatnot. We're running, you know, in order to keep them sedated and to ventilate them. Not only are we running high doses of sedatives to keep them asleep, but we also run paralytics. And we will run, like, we have been running paralytic infusions for a week, and there's no, you know, the studies show, like, even running a paralytic for one day, it takes a person about 7 days to clear that out of their system. So when you consider we're running paralytic infusions for almost up to a week, we're trying to get away from that now. It's taking, forever for these people to wake up. And that's with optimal organ function. But when you consider we have other patients that have comorbidities such as liver cirrhosis or renal issues, you're multiplying that by like 3 weeks. Like we're just starting to see, like, you know, the side effects of this. And unfortunately, like, some of our patients that we've had on these drips for a long time, of course, they don't wake up the same, or they've developed microclots and have to go for MRI and the whole bit. So it's been a learning experience for us too. So now we try our best not to, run continuous paralytic infusions, for example. We just give them as needed for ventilator asynchrony. But yeah, it's been very interesting in terms of the drugs, and it changed.
So the other name of remdesivir,
Oh, it's
Vecuri.
Veclurvy or something like that. That's the trade name. But I don't know if there's another.
Canada may, like,
There's a different cyclovir. I'm thinking probably that we.
Yeah, it got kind of pushed through by the FDA, and it actually ended up with a full approval. And then the World Health Organization finished a big stage 3 trial and said it doesn't do jack. And actually, when you look at the side effects,
Well, now it's
probably
poo-pooed
killed
down
you
here
faster.
because of the renal failure.
Well, yeah,
potential.
it's renal failure. And I mean, the thing is when you're already in an ICU, what usually tips people over with a regular pneumonia, right? They go into multi-organ failure, and they tip over one organ, and then it's the next, and next, and next, and then that's the end of
Exactly.
that. You're having a talk with the family and extubating them. I mean, that's how it works.
Mhm.
So, but-
So mostly steroids then.
Mm-hmm.
Okay.
Immediately, blood. So yes, immediately steroids, blood thinners, just standard.
yeah, it's interesting because there's guys in the early treatment protocols now that are using things like apixaban, like in the outpatient world. I mean, they say everybody. I didn't take aspirin when I got COVID. My breakthrough infection. 6 weeks ago or whatever. But they advocate at least antiplatelets. But a lot of them are like, man, as soon as you start getting short of breath and you got to move to like oral steroids in the outpatient world, you should actually just put them on one of the novel anticoagulants because it's super safe for a short period of time, and it may make the biggest difference on whether they go to the hospital or not.
Yeah, I completely agree with that. I think, that's the way to go right now. We are seeing a lot of patients, like I said, come in with all these microclots or MIs as a result of COVID. So
I want to get back to the unvaccinated people because there's a stat you may not know about, because I don't know that it's recorded. Because the CDC about 10 months ago stopped, not 10 months ago, it's probably March. They stopped counting breakthrough infections, and they only count a breakthrough infection in a vaccinated patient if they're admitted to the hospital, which, may have changed the arc a little bit because, I think it's pretty obvious that vaccinated people are probably the biggest spreaders of this. The problem is they spread it to unvaccinated people, and then they get show wasted. Like they just get annihilated with the disease because you have somebody who has a leaky vaccine I was very minimally ill. I tested positive. I clearly had symptoms.
She knows you didn't make it to Canada,
but it was
down up there.
I know,
It's bitter.
but it wasn't
Bitter. We're being serious for the show, but we're all bitter at you.
I'll be bitter.
that's right.
So, how much of that was the vaccine? Maybe all of it. I don't know. I did an early treatment protocol. Did that help? Who knows? Like, whatever. Great. Now I have super immunity. But there's a group of people that I'm really, really concerned about. And it's the people that are newly vaccinated that go into the unvaccinated group. So if you're vaccinated with your second shot or your 1 week post J&J, those people, at least here, are in the unvaccinated pool if they're admitted to the hospital. And my concern is that in that 1 week, 10-day period post-vaccine, I think that you're really susceptible. My guess is that this vaccine, because every coronavirus vaccine prior to this has caused antibody-dependent enhancement, that's always worse as your antibodies are ramping up before you get kind of the full effect 2 to 3 weeks later. And so have you heard of that? Have you had any patients where they're like, well, he got the shot, but it was like 5 days ago. And then, they went to a football game and they got sicker than hell.
Right. I have had that happen, but not with that many people. It was 2 patients I can think of, like off the top of my head. And one of those was a gentleman who was 80 years old. And he had just gotten his second shot, and it had only been a week. He passed away. And then the other person I can think of as well had been about 7 days, and they were in their 60s. And I believe they lived. But generally speaking, what I've been seeing, I would say 95% of the patients that I have dealt with or have seen that have come in with COVID have all been unvaccinated.
Yeah. And I think that's, what everyone is seeing in North America right now. I mean, the UK and Israel, it's a little bit different. I mean, they also have way higher vaccination rates. So, part of it is, I think, waning immunity. And part of it is just the fact that if you have 90% of your population vaccinated and you have anybody in the hospital, chances are they're vaccinated. I mean, it's just statistics. It's the way it is. But, we've had 2 friends, and it may be it's totally anecdotal, but it's fascinating to me. We had 2 friends that got COVID within 2 weeks of the vaccine and got unbelievably sick. My one friend almost died. He had small cardiac infarcts.
Sure that, obviously that's happening. That's a danger zone, but I don't think it's the majority of people that are getting admitted to hospital that are unvaccinated.
No, of course not. The majority of people are just not vaccinated, and they're getting, the fact is that with the Delta variant, whether you're vaccinated or not, in your nasal passages, you have the same amount of viral load, regardless of vaccination status. And unfortunately, that viral load is about 241 times higher than it was with the Alpha variant or the original COVID.
So I want to know, I kind of know this already from talking to you earlier, but what is it, or what are people asking for? Of course, people are wanting, the sun and the moon to save them, to save their loved ones once they're in there. Tell everybody about the kind of requests you're getting for drugs. Are you getting requests for things around the world? The big I right now,
Oh, yes.
and that kind of a thing.
Just the other day, we had a family member ask for ivermectin, and I had to laugh because a few of my coworkers, they also have farms. So they're like, the one nurse said, "Oh, do you want your husband spayed too while he's here? We could do that."
Well, why wouldn't you give it to the patient? Like, if it's so unbelievable.
Well, in an ICU setting, I don't have to ask ultras.
No, but it's so
It's
unbelievable.
like saying, once you're in the hospital from renal failure, can I have some
I think
some I lost the name for it, Eurostat, because it hurts when I pee. It's
but the fact is that if you actually, there's a part of ICU medicine that's caring for the family. And you can sit there and you can say, look, I don't, the ICU doctor comes in and says, I don't think this does anything. But it's so unbelievably safe that if it makes you feel good and your loved one's going to pass away anyways, and we did everything and you feel better, why would you say no to that? To me, I think that's irresponsible.
Yeah. Well, I don't know what Heather.
If they wanted to bring it,
she's just there to.
No, but
with doctor's orders, basically, right? But he went off about how we should offer them the moon.
Well, no, but I think that, I would.
I get mad.
What's that?
Offer them the moon. No, we shouldn't be offering.
No, but I think that it's not unreasonable to give somebody something that's not dangerous. If somebody said, we've had people that are brain dead, and they're like, can't you do another CT scan, or can't you do whatever? And it's just like, well, they're brain dead.
Yeah.
So,
But I think there's
you
a
know,
place to say, I'm not an ICU doc and I don't know, but literally, whatever the case may be, I agree with you that sometimes there's a place to say to the family, we that's probably not going to work. We understand you're reaching. I mean, I know you guys intubate and ventilate people who have no business probably having that offered to them because they're probably on death's
right.
doorstep anyway. Right? So it kinda goes both ways, but, if the medicine's really not gonna work, I mean, I think it's always informed decision making with your patients to sit down and go and say, "This works really good as an outpatient medication in COVID, maybe if they were on the ward, but in an ICU setting with complete organ failure, it is just like peeing in the wind." I mean,
Right.
so, I mean,
But if they're
there's
freaking out, I mean, for God's sake, they did this
Yeah,
mother.
right, but it's all
We
about
gave your mother ionotropes to keep her alive so Heather could get down here and say goodbye to her.
Correct, but it's about style, right? I mean, as far as
Right.
it's all about style and relating to your patient. Right.
Right. But this has become such a political thing where we have people that are getting that they're getting court orders, which also, I mean, I'm not sure what I think about that. But at the same time, it's just like, no, because I said so. And I'm like, well, it's one thing if it's dangerous. It's one thing if you're doing a dangerous intervention. But when there's nothing left to try, or if it's like ridiculously expensive, like we see this in cancer all the time.
So,
You see these drugs offered in cancer therapy that give people an extra 2 weeks, and it's 13 grand a month.
okay,
Like, why they offer it all?
but I'd like to interject if I might. The difference is, though, I mean, that's in an American system, right? So in Canada, I mean, to do a repeat CT scan when we know that they're brain dead, or to repeat, an MRI, it's not fiscally responsible, first of all, to be doing that. If we know that they've had the CT scan, this is my opinion and belief, just it's not, and to move an unstable patient to start with is a task in itself. So if someone's asking me to send a family to do another CT scan or do another MRI, there's a lot of factors at play. First of all, cost. Depending when the test is done, do we have to call in a radiologist in the middle of the night? The third thing would be, you know, again, is it warrant moving an unstable patient? Because they are going to
No,
die at what point, right?
and I would never argue doing something like like advanced imaging
Mhm.
on a brain dead patient. I mean, I get that. We've done that. We're like, they're brain dead, but we
Right.
really want to make extra sure, so we're going to do a CT scan. I mean, I understand how that works, but with ivermectin, it like for God's sakes, it's $4 a pill.
Mhm.
You give them 5 pills down the G tube, and it's like, okay, well, we tried it, it didn't work. Okay, we tick the box. I mean, I don't see how that's not egregious. It's not expensive. It's not disruptive to patient care. Because yes, you're right. With some of those advanced imaging on a very unstable patient, you could kill them by giving them the scan.
Exactly.
So that's totally irresponsible, especially if you have to do a contrast study.
And I have to say too, like it's physician directed. So we have, I work with a great team of physicians, but with that being said, there's a broad spectrum of how they do their medicine. And it can be very frustrating as a nurse, for example, having one physician that comes in and says, okay, yes, we're going to give the ivermectin. We're going to run methylene blue. Yes, we know they're in kidney failure and they're going to die anyway, but we're still going to do this to give the family peace of mind. Whereas, if we run the spectrum, having other physicians say, no, we're not doing this. We're not doing these last ditch efforts because we know it's futile and we're trying to be fiscally conservative, fiscally responsible. In addition to which, we need the bed. So
Right.
it's
I
at
understand
that
that
point,
completely.
it's at that point now where we need the bed. So I would anticipate within the next coming weeks that physicians are going to have to be making some tougher decisions. And that will be, should we be traching a patient to, what's their prognosis? Is this 75-year-old getting out of the hospital with some quality of life as opposed to, the 30-year-old that came in with COVID right now?
Somebody that shows up that's been in a car accident that needs the bed that's 30 years old and you're dicking around.
Yeah, I'm really surprised I'm really surprised that there's that much intra doctor difference. Like, I get it if you're gonna.
Are you really? Come on, we did ICU.
No, not with no. Like, yeah, if you want to give somebody ivermectin or not, whatever, that's not that big of a deal. But I mean, who you intubate, how long they stay intubated, whether or not you get a trach. I mean, I would think that that would be. I mean, that should be pretty buttoned up with your department. I mean, like,
There are
trachea don't have any.
guidelines that we follow loosely, I would say. So typically, if someone's been ventilated for 2 weeks, that's when we are like, okay, it's time to put a trach in. I can think of a few, on my hand where it's been, well, maybe because they're on minimal ventilator settings. So it's like, well, maybe we'll hold off because maybe we can get the tube out kind of thing. But they're not waking up. Such is the case of one of my COVID patients. Same thing, like wouldn't wake up, but completely, ready to extubate, but they're GCS 3. So
So
So I would like to take it to the other side for the people that aren't medical, and not for everybody, to talk about the other side of things, which is the emotional side and the toll that's going on the nursing staff, um, doctor staff, but everybody in general, and what your experiences have been in this whole thing. I mean, I know it, but I want you to share with everybody from the medical
I want to
perspective.
start that off with when you guys were super mega locked down, a year ago. So you were doing like hardly any elective procedures, et cetera, I would assume, correct?
right, yeah, definitely.
So were nurses laid off then?
No. So what happened was, and it is happening right now, actually. Um, so in those departments, they would be redeployed to areas where they could be utilized. So, for example, operating room nurses got redeployed to go work in public health and assist with contact tracing and phoning everyone that's been exposed and talking to them about, whether they needed to self isolate or self monitor. Um, testing in that regard. We also had nurses come to us that had previously worked in ICU that were redeployed. So they were forced to come back to ICU and help us out with our patients. We just didn't have enough staff. And then in addition to that, we also had regular ward nurses that did come to assist us under our direction and supervision. They were able to, help with patient care or, mixing up of drugs and whatnot, at least to kind of free up the ICU nurses to do all the ICU type care. And that's what's happening right now. Um, we're seeing that right now. We don't, they're opening, we have 15, we're supposed to be staffed for 15 beds. We just opened 3 more beds, bringing us up to 18 beds. And by October, I believe the 12th, they're going to be opening up to 24 beds in my ICU.
Wow.
Where are these nurses coming from? I
Yeah.
I don't know what to say. That of course, they're being redeployed. Um, I just actually accepted another position outside of ICU, and I am not allowed to leave. So I'm going to be forced to stay in the intensive.
So you're being mandated to work in ICU
Mandated by the
because you have
government.
that training.
There's been a government order issued, a letter of understanding that gets reassessed every 6 weeks, where all elective procedures are stopped. The nurses are redeployed to other areas where they can assist, and it is a government mandated order. I'm
Are
not.
they doing that with other healthcare workers other than nurses? Are they doing it with physical or
That in-
respiratory therapists, physicians, anyone else?
I can't speak for physicians, but that also includes, so with the government that covers SUN, the Saskatchewan Union of Nurses, it covers the union called QP, which so that would be laundry, um, uh, laundry,
Oh,
housekeeping,
wow.
LPNs.
Really?
So,
Laundry?
well, yes, but
Right. No, it's a separate union. It's your non. It's your non.
Oh,
It's your.
oh, yeah.
It's your,
Sorry, my
it's your,
bad.
it's your non. Essentially, your non
Falling asleep at the wheel. Yes.
right, and that includes
Right.
respiratory.
non certified.
Right.
So
Okay.
we've just been, just as of late, we've been talking about how are we as nurses gonna manage this? So the plan is the tentative plan is it'll be 1 nurse to 2 patients. Um, and then there'll be myself, the 2 patients, and another ICU RN with 2 patients, and then we'll have an RN assigned to us that's not ICU. That will that's
That's
what
helping.
with helping
Gotcha.
tasks. So we'll be running the ventilators and the drips. But that in itself is
So how's that gonna go, Heather, since we know what the last 2 years have been like? Yeah, on everybody, not just you, but your colleagues,
it's been
like
tough.
the strain.
Right. We're exhausted. We've been working a lot of overtime just to help each other out. Working in an ICU, we are smaller staff and we're like a tight knit family. So we do our best to come in and work extra hours to kind of try and help out, especially with this influx of patients that we've been getting over the last couple of months. Um, and as I was saying, there's been a lot of problems for my coworkers at home, whether or not their spouses believe in vaccines or they're anti-vaxxers or family members. It's caused a lot of problems in their marriages. I know of a few my coworkers have expressed that a lot more alcohol use, um, and of substances like marijuana or whatnot. So a lot more nurses are drinking more and just to kind of make it through. Um, and not only that, I mean, we've lost our empathy. We all went into this definitely not for the money. We all became nurses because we care about people and we want to make a difference and help people. And in the last, especially I would say more so in the last 3 to 5 months, um, we've all been tested psychologically and emotionally, and it's affected our ability to have that empathy for our patients and provide that hope for their families. I think it gets old really quick. We say the same thing over and over. Well, oh, my family members should have gotten vaccinated. As a nurse, you're thinking in your head, you're damn right they should have. Um, it's really hard having to, answer the same questions repeatedly from various families over and over about why can't we give them ivermectin? Why can't we do this? Why can't we do that? Or the patients themselves like admitting right up until they get intubated that COVID is not real. COVID is, I don't have COVID. Well, when you show them the test result, yes, you do. This is what you have. You have COVID. And so, and you get a lot of families in denial still about COVID, that COVID is not real. And I think that's, you know, and it's tough to be fair and objective with families, because it is a very emotionally charged, you know, an emotionally charged thing. And so going into work day in and day out and having to deal with that really test the strongest emotionally sound, stable person as it is. And when you throw other things into the mix, such as existing depression or, you know, disorders and or anxiety disorders, it can definitely push the most balanced individual, you know, to the edge. And I think I think the biggest takeaway from all this is families. It's dealing with the families that have been the hardest. It hasn't been the patients. The patients are, do I'm so sorry or do everything you can to save me. But the families, it's dealing with the families that have been the toughest for us. Um and I understandably, I mean, there's, families come with their own guilt. They come with their own family dynamics and some of the things that we deal with as nurses, of course, family dynamics have nothing to do with us. Um, they just get taken out on us. And you have to have a really thick skin to work where I will, because you bear the brunt of the family's anger. You bear the brunt of the family's questions because the doctors can't be there 24 hours a day, of course. And we are there, for the whole 12 and a half hours with that patient. And so families get upset, they get angry, they question us, they challenge us, um, which is fine. But but being repeatedly subject to that day in and day out really wears on your psyche. And now we have protesters protesting outside of hospitals here. Um, they take their turn, I believe, and go to the different hospitals. But we have a select group of anti-vaxxers that are now protesting outside of our hospitals. So coming into work every day, it's really tough to see that. And you go into work knowing that the majority of people that you're saving come from a subset of these people that don't believe in vaccinations. And it makes your job difficult.
Everyone has a breaking point, though. Like, like it doesn't matter who you are. I mean, Jesus went to the other side of the lake after he got sick of dealing with people. It was like the crowd pushed him and pushed him and pushed him and pushed him, and he went across the lake and took a nap. And then the storm came up, and then walking on the water and the whole deal. But like that struck me. It's like the point is everybody in humanity, even the Son of God, has a breaking point. And it doesn't matter how much you pay people. It doesn't you can't buy that back. You can't buy your jacked up marriage or whatever because, you made bad decisions when you got stressed at work. I would think one of the hardest things to deal with is the fact is that no one has any clue when this is going to be over. The assumption was we're going to vaccinate 75% of people and it'll just go away, which has been a total failure. Honestly, I think the vaccines made this worse. I think the vaccines pushed the variants. You never vaccinate an RNA respiratory virus during a pandemic. Never. You'll get what you get now. You'll get partial protection, and the people that are unvaccinated will get really, really sick. But what ends up happening is because it's blanket vaccination, it pushes all this and makes it worse. And, we'll have that study out in about 8 years. So that'll be super helpful.
I think the bigger point, though, is no matter what you believe scientifically, no matter what you believe politically, the emotional toll with the pandemic, with the family members, but with dealing with sick ones and seeing death and dying, it doesn't matter. Take all the politics and what side of the aisle of whether it's remdesivir or ivermectin or hydroxychloroquine or whatever, how long to intubate you're on, just the continuous strain of where you're at with dealing with everybody's stress level. And you're short-staffed, you're tired, you're burned out, and you're dealing with death and dying this is like this end of the second year, like unprecedented. Like I know you told me that you saw more death in that 1 month than your whole career.
Than I did all of last year.
Of all the year before.
Yeah, in January, some more people died than I had all of last year.
And so forget COVID. If you just had that happen from, I don't know, a terrorist attack, like what is that going to do to
well, of course,
you're a professional, but you still have to process each case in itself. And you just layer that on. It's like telling someone to deal with 10 family members dying, a divorce, 3 pets dying, and
it doesn't matter. It doesn't matter who you are. Everyone has a breaking point. And the fact is, they're not going to collapse the system for lack of ventilators or lack of hospital beds. They're going to collapse the system. In the United States, in Canada, it's really no different. They're going to collapse the system because they don't have staff.
And I think
I did my thing. I did my year. You paid me extra. You did whatever. I'm done now. I cannot do this anymore. I will not sacrifice my family.
And a lot of what the public doesn't understand is, just get more nurses or bring nurses from wherever. And what people fail to remember is we ICU nurses, we're specially trained. We go to school. We take extra school to be trained how to work there. It's not a matter of just bringing any nurse in and dumping them in and say, okay, here you go to work. We're trained to run ventilators. We're trained to run different types of drips and paralytics and all these things that most nurses don't do. And no, we don't get paid more for it either. Just as an aside.
Oh, yeah, no.
Wish we did, but we don't. People ask me that all the time. No, you must make more money. No, I don't.
COVID hazard pay? What's that?
Go work in long-term care and make the same amount of money, which is sounding pretty good right now. So,
but you can't because you're being mandated today.
So that's the other thing. Yes. So, yeah, so we're being mandated to stay. So I actually accepted a position outside of ICU. I'm very excited to start it. I'm at the point in my career where I'm burnt out, and this pandemic has just pushed me to that point. Um,
So if they mandate you to stay
right.
and you have another job, right?
Mm,
And then you have to stay in the ICU, which I understand from their perspective because they're like, you know,
right.
this is where we need you.
Right.
Then what? Your only alternative is to leave nursing?
Basically, yeah. Basically right now, or go work outside of, or go work in the private sector would be my other option at this point. So, so yeah. Yeah.
And so tell us a little bit,
Why you don't give up your guns?
that's a whole other episode. Okay, tell
Also, why you don't give up your guns?
how well they've got knives and breadsticks.
Yeah, I was gonna say we don't guns here. We have knives and machetes.
We do all about it, and baseball bats, right?
Yeah.
How about are they doing the same thing as down here in the U.S., where if you're not vaccinated, you will be let go,
Mm,
or put on
Oh.
permanent administrative leave with no pay?
right. So that's just something actually that's come up within the last week. And from what I understand, they're going to make it mandatory that all Saskatchewan healthcare employees are vaccinated. I believe it's by October the 1st, but I could be wrong. Um, I know a friend of mine who's
So
works
that
at the city. They also have introduced mandatory vaccines as well.
so
And
there you go. You could tell them, Heather, that you're not vaccinated, and you would be out.
Be better.
There's your out.
Be better to get a private sector job.
Tell them you lied about your vaccine and you're out. Therefore, you must be released.
Yeah, I mean it's tough because this is emerging, right? I mean, we've had 412 deaths in kids in the United States, so that kids are more affected by Delta, but it's still like nothing, like
and
nothing in
I
comparison
could go work
to
in the
adults.
private. I could go work in the private sector, and that's actually I have had an opportunity presented to me, as such, to do that. But um, it all comes
It's so hard.
to choice in life.
How do we?
And when you work with a group, like I've worked with these people for 7 years, you're like, you know what it's like. You're a tight knit family, and you do your best to support each other. And I mean, at the end of the day, I'm just a number to the health region, but you know,
Yep.
you do want to help and do your part. Um, but then at the same time, that's just it, right? What is your breaking point? What is your I think I'm at mine, but I don't think they really care. So
No, but the thing is, I think that's a really important discussion. Like when is it too much? Like,
hmm,
I mean, you want to take one for the team, and you want to, May and I both been in situations where we took one for the team way too many times, and you look back later and you're like, well, I should have left that 6 years before I did, but I was being the good soldier. Well,
right.
for what reason? Like, again, it's not because the health region is going to give you a special plaque or something. I mean, it's not going to happen, right? I mean, they just need to plug the holes with whoever they have.
We can't even
And so, I mean,
box of donuts because
right.
that's infection
Oh my!
control issues. We're not even allowed to order pizza in as a group unless the pieces are wrapped individually.
Oh my gosh!
Yeah, for real. Yeah.
So
They need their own PPE, pizza PPE.
pizza PPE. Yeah, that would be.
But I mean, honestly, I think what I want the public to know is at the end of the day, the healthcare personnel are like over it, done,
We're over it.
exhausted, and I don't want this to be the discussion about whether you agree with vaccinating for COVID or not. That what's
Right.
happening down here is so many people who don't want to be vaccinated or in healthcare are now being let go in the middle of a pandemic.
Mhm.
So now we're losing more healthcare workers, and we're losing ones that are vaccinated because they're burnt out. Both sides, and it's not good. It's not good. And I don't know. I mean, I don't have the answer, or I'll be
Well,
President
no, but I
Camilla
mean,
Biden or
it's
whatever.
clear. It's clear. It's clear. I think.
Anyway.
I think. I mean, I know what I'd have done differently. And if you read pandemic preparedness from before 2015, this basically everything they did was the opposite of what
Yeah.
they initially planned on doing,
So
which is very interesting. But there is no answer now. Is there any early treatment? Is there any monoclonal antibodies being used? None?
in Saskatchewan,
Zero? Like you can't go to an urgent care and get an infusion of Regeneron
Could you-
Cove?
could you get some hydroxychloroquine or ivermectin?
So there's no early treatment, because early treatment is the only thing that's going to save our butts. And it, like, whether or not, like, you can take the ivermectin and the hydroxychloroquine and all the politicized stuff and you can just throw it away. There's still early treatment that's effective. Regeneron's 2 antibody treatment is, according to the CDC, 75 to 90% decrease risk of hospitalization or death,
Okay, so they're not using that at all in Canada.
and steroids.
Not that I'm
Right.
aware of. I'm not really up to date on, to be honest with you, on the early
Right.
treatment,
But
because I
is-
deal with the acute.
right,
Right, but
anybody
but
you
you
know
know.
that's been getting COVID,
Right.
Because they,
friends personally, they're not getting any kind of
Thing that I'm aware of.
nutraceutical pack or anything like that. All right. So, anything else you want to ask Heather about her personal experience
no,
in your home
but
country?
it is insane that there's no early. I mean, the early treatment stuff, I mean, that's a whole other bunny trail. But
Yeah.
I mean, there's politically correct early treatment now. Should be doing that so they don't go see you. But
Call up Justin and take it up with him.
Exactly.
he'll be speaking moistly.
He will. We'll have a
In
chance
the election.
to deal with that.
Thanks, Heather,
You're welcome.
for being here, sharing the story up in Canada as it's been going on. And we'll keep our listeners posted as to any kind of changes going on and whether you stay, go. Should I stay or we'll have to play that song.
But
Should I stay or should I
I
go?
think we've established that I'm going. It's just when will they let me go?
Yeah, well,
When
exactly.
Yeah, no, and
hours that
you were a tremendously good sport. And we really appreciate what you've done. I mean, like we were a frontline worker, but we're outpatients, so who cares, right? It's just like, oh, you're sick, go to the hospital. And there was some early treatment that we're able to prescribe, steroids and whatnot. But the nursing has a very particular burden that I don't know that many people understand. And I always called it the closed units. So the ICU, obstetrics, and the ER, where the nurses are always there and they do virtually all of the hands-on patient care. I come in at the last minute and deliver the baby and write orders and all the rest of that. But who's there counseling that patient for God knows how much of labor, or telling the family that, we're going to have to paralyze, your father because he needs to be on a ventilator. And the doctor comes in, does the talk, does the family thing, and then you're there reinforcing all of that 12 and a half hours at a time. And I don't think it gets the credit.
Absolutely not. Absolutely not.
So we appreciate you a lot.
Yeah. All right. Well, love you, sis. Hang in there. And as we wrap this up, we have to tell our listeners to remember our fun Dr. Seuss poem. And if you're thinking of doing locums and not leaving the country, they look up locum story.
come to Canada, we need doctors too.
There you go. Or don't look up a story and cross the border. All right. Next week, who knows what we'll be talking about, but it's probably going to be more COVID since you're beating down our doors and our email. Reach out to us at doc@bsfreemd.com. If you have any questions, we prefer that. And we've been getting a lot of questions from people, which we appreciate. But remember, we cannot answer specific medical advice for your personal situation. And as much as we'd love to be everybody's doctor, we can't. So we will reply as best we can with some general medical guidance. Other than that,
Or just questions like,
take
hey,
this
why
for
don't you
your
guys-
entertainment first.
why don't you
purpose.
talk about this on your next show
Yeah.
instead of, my right nut's bigger than my left nut. I want to know if there's anything I can take for it.
All right. And with that, see you next week.
It's no secret that medicine is a bit, uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS3MD. See you next time.
While we try to keep BS3MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bs3md.com.